Hi everybody, Dave Bosch again, coming back with the second part of the rush exam. Today we're going to talk about the tank. The two parts of the tank evaluation are the IVC eval and the EFAS exam minus the echo. Reviewing what we talked about last time with the pump, the first portion of the rush exam is going to be a quick echocardiogram looking for a pericardial effusion, and then looking at left heart evaluation for global estimation of EF or a more detailed estimation of EF by EPSS, and then looking at right ventricular strain. Talking through the tank, I want to start out with a case I had at Littleton a couple years ago. This is a 24-year-old male presenting after syncope. He came in by ambulance, had no past medical surgical history, and complained of a viral type illness for the past couple of days with sore throat, fever, malaise, just didn't feel well. He had no abdominal pain or cough, no urinary symptoms. He came in hypotensive, tachycardic, febrile, tachypnic. He was sitting 99% room air, but he looked unwell. He was pale and tachycardic and had tonsillitis. He had a soft, non-tender, non-distended abdomen. And I would stop here and ask you how you would typically proceed with a patient who looks like this. I think most of us would call a sepsis alert. We would put in fluid boluses. We would order lactates and labs and VBGs and proceed with whatever other testing we thought was appropriate. Based on his symptoms, sore throat, fever, and malaise, I had not really considered much advanced imaging at this time. We ordered labs, which came back fairly quickly with a white count of 35,000, a hemoglobin of 10, high platelets, a high lactate, an anion gap, all looked still like significant sepsis physiology. So I want to pause from the case and talk about the tank and look at the IVC evaluation. The probe position for the IVC is subxiphoid with the curvilinear abdominal probe. It's in the longitudinal axis, so up and down, with the probe dot facing towards the head. You want to put the probe midline high on the xiphoid, high enough so that you can see the right atrium on the corner of the screen. On the right picture, you can see this is a perfect subxiphoid view of the IVC because you are looking through the liver, you're seeing the IVC in a long axis, and you're seeing the right atrium on the left side of the screen. This is how I learned how to evaluate the IVC. I used to memorize how big the IVC was and the percent it collapsed, and I'd correlate that with a known central venous pressure. I think this is way too difficult to try to remember, and it really doesn't give you that much useful information. I would recommend simplifying. Go for the extremes. So on the left, you've got a very large dilated IVC. It looks like a pipe. You can measure it or you can eyeball it. This one is over 2 centimeters. A lot of our new ultrasound machines have auto IVC calculators that you can use this function, and it'll automatically tell you the size and the collapsibility of the IVC. Notice in the picture on the left, you can even see that dilated hepatic vein swells. This all correlates with a very high central venous pressure, probably 15 to 20 or more. Conversely, on the right picture, you see a very small collapsible IVC. The walls are touching and kissing with inspiration. You can see the heart on the left, and this is another perfect picture through the liver, but you can see the difference, and very quickly the IVC would be considered very small, and this would correlate with a CVP of low, so less than 5 probably. Anything in between is usually fairly normal. You're really shooting for 2 centimeters and about 50% collapsibility with a sniff. The next part of the tank evaluation is a FAST exam. I think we've all covered FAST exams, so I won't labor this too much, but we see pictures here of free fluid in the Morrison's pouch. This is a picture likely of the right upper quadrant showing fluid both above and below the diaphragm. So this is both pleural fluid. We don't know what it is. It could be blood, it could be simple fluid. And then there's also fluid below the diaphragm. Next, you want to put the change probes usually over to a linear probe and rule out tension pneumothorax as a cause of hypotension. Hopefully your physical exam would have led you to something like this sooner, but if you're there, you're there. And so it's nice to be able to rule out pneumothorax. If you need more advanced tips and demonstrations on how to do this, go back to my YouTube page and look at the section on pneumothorax. So back to the case. I did a fast exam on this patient because he looked quite ill. The fast exam was remarkably positive for free fluid in the abdomen. He had no history of liver disease. So we sent him immediately for CT abdomen pelvis, which showed a ruptured spleen. Then we tacked on a mono, which came back very positive. And instead of ordering IV antibiotics and admitting the patient to the medical floor, the ICU, the patient went immediately to the OR for emergent splenectomy with general surgery and got blood products on the way. So you can see how this was a very different end and outcome on a case that appeared fairly straightforward from the get-go. And so that's it for the tank evaluation. Next time, we're going to talk about the pipes, and then after that, we'll talk about how to put the three pieces of the rush exam together so that you're using it in a timely fashion to figure out why your patient may be hypotensive. Thanks for tuning in.